We present a case of an 84-year-old gentleman who was diagnosed with pancreatic head adenocarcinoma 2 years ago. At that time, he had bile and pancreatic duct stents with resolution of jaundice and improvement in diarrhea. Over the past month, patients started complaining from epigastric pain, nausea, and vomiting. Cross-sectional imaging demonstrated no significant change in pancreatic mass size, with intact stents and stable pneumobilia. An upper endoscopy was then performed, demonstrating narrowing of the second portion of the duodenum with inability of the endoscope to traverse this segment. Contrast was injected into the duodenal bulb, showing evidence of severe narrowing of the second portion of the duodenum. A long ERCP guide wire was advanced through the upper endoscope past the duodenal narrowing and looped into the distal duodenum. The endoscope was then withdrawn while maintaining the guide wire in place. A dilation balloon was advanced over the guide wire into the distal duodenum and inflated to 18 millimeters. A linear echo endoscope was then advanced into the stomach. The dilated balloon was identified and punctured with a 19-gauge needle, noting immediate contrast to dissipation into the small intestine. Another guide wire was advanced through the 19-gauge needle into the small intestine. An electrocautery-enhanced axial stent was then deployed over the guide wire into the lumen of the small intestine. The stent was then dilated using a 13.5 mm dilation balloon. Final endoscopic and fluoroscopic appearance appeared satisfactory. Patient did well after the procedure with resolution of symptoms and was discharged the next day after tolerating a regular diet. However, a patient presented about 2 weeks later with right upper quadrant pain, fever, and increase in bilirubin from 0.4 to 2.6. A transabdominal ultrasound showed worsening intrahepatic biliary dilation. IV antibiotics were started with improvement in symptoms but persistence of lab abnormalities. We then discussed with the patient the options of percutaneous drainage, EUS-guided hepaticogastrostomy, or an attempt at exchanging the stent through the newly placed axial stent. Patient opted for an endoscopic intervention. A therapeutic gastroscope was used and normal bowel mucosa was seen through the axial stent. Contrast was injected through the stent to delineate anatomy. An ERCP retrieval balloon preloaded with a long guide wire was advanced into the afferent bowel and the wire manipulated past the stricture and into the duodenal bulb. The endoscope was then removed while maintaining the guide wire in place. The endoscope was then re-advanced into the stomach and the wire grasped from the duodenal bulb and pulled out of the patient's mouth so that both ends of the wire were accessible. A Sohindra dilation catheter was advanced over the duodenal end of the wire to provide stability, and the scope was advanced over the jejunal end of the wire. While applying tension to both ends of the wire, the endoscope was advanced into the second portion of the duodenum through the axial stent, and the stents were visualized. Once this was achieved, the wire was pulled out of the scope. Using a rat tooth forceps, the biliary metal stent was grasped and retrieved through the accessory channel of the endoscope. The pancreatic plastic stent was inadvertently removed at the same time. Contrast was injected, filling the biliary tree along with the duodenal lumen, demonstrating mild intrahepatic biliary dilation and few filling defects in the distal bile duct. A retrieval balloon was advanced into the bile ducts and multiple sweeps were performed, removing a large amount of sludge and amorphous stones. A final occlusion cholangiogram did not show any filling defects. A 10 mm by 10 cm fully covered metal stent was then placed with the proximal end just distal to the biliary confluence. Finally, contrast was injected through the scope at the site of the gastrojejunal, which confirmed an intact anastomosis with no evidence of extravasation. Patient's symptoms improved and his liver function test normalized the next day. In conclusion, the use of a gastrojejunal stent allowed for biliary stent exchange despite duodenal obstruction, simulating ERCP done in patients with a Bile-Roth 2 anatomy.